Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Victor. How are you doing today?
I'm doing well today. How are you, Dennis?
Doing well. And so today I'd like to talk about Burma and your experiences in Burma and all the ins and outs of what you did over there. So since it's the first time on your podcast, on my podcast, would you mind doing just a quick introduction of yourself?
Yeah, Dennis. My name is Victor. I was a former 2nd Ranger Battalion guy. I started off as an infantryman, and I was infantryman till I did my fire team leader time. After being a fire team leader, I went down to SOCM, reclassed, and then I came back to 2nd Ranger Battalion as a medic. Spent a little bit of time there as a medic, and then I got out of the Army, and I came down to Vegas to be a firefighter paramedic. Did that for about 2 years, and then I went on my first humanitarian mission with Free Burma Rangers. I just got back about 2 months now. I was there for a total of like 7 weeks, about a week and some days in a training camp with Free Burma Rangers, and then 6 weeks in Karenni State on the heavy conflict areas. And
Perfect.
Recently resigned from being in the fire department, and now I'm working for North American Rescue, and I am the tactical medicine program manager there at North American Rescue.
Perfect. So, since you just got back there recently, and at least in the news, there's been a lot of news about sides changing, powers changing. Would you mind just giving kind of like an overview of what was the environment like? What was the situation on the ground?
Yeah, so reflecting the news and the timeline, and I could only really speak for the region and the AO that I was actually in, and some reports that I can hear from different regions within Burma. But essentially, when I first got there, the tide of the war was essentially on the playing field of just pretty even, but the ethnics were definitely building up their cachet and their momentum. And by the time I left, that plane had shifted to where the ethnics were on the side of gaining a lot of ground and getting some of the first big wins that they've seen in the war. I got to support one of the in Shada, which is a medium-sized valley with actual structured homes. We supported them, and it was 100% clear from Burma Army bases. And that region is pretty much freedom of maneuver for ethnic forces at this moment. And they're continuing to clear through multiple medium-sized and large-sized towns and cities inside of Karenni State now. So the ethnics are pushing hard and fast right now.
Nice. So, being from Ranger Bat, generally their mission is not necessarily hearts and minds. How was that, taking that education and now volunteering with Free Burma Rangers? How did you kind of prepare yourself to go now teach indigenous folks on combat medicine?
I think a part of it was being a ranger. You start developing the tools of teaching and training and focusing on the basics. And so I knew I wanted to bring the basics over, and also just being a ranger and being very familiar with Rollo.
Yeah.
And talking to some people over there, I recognize that Rollo is something that hasn't been brought over yet. And it's one, a problem with logistics, and two, a problem of education. And I've never had proper training on training and developing an ethnic group, but really it boiled down to just being a human. And being open to accept culture and understanding culture and respecting that. And I had good mentors when I got there of what the cultural environment was like, and then molding training to your students.
Okay, perfect. So now, you get this mentorship, you go through this training course, and then they start pushing you forward so that you can now, start training, start operating. One was the training that you got. Did that actually reflect what you saw?
The training as far as like as a humanitarian.
Yeah. That 1 week before you went in.
So that one was more so of like not a proper training, but a conversation of the foreigners that have been successful over there of like, hey, like these are little nuances and everything. And then kind of talking to like the ethnic leaders that have been working with foreigners for a long time and just having that baseline conversation of like, what's the expectation here? And after that was once I actually meet who I'm training, I always started off with what's your background before this revolution, before you joined the revolution. So that level would be anywhere between I did 10th grade twice and then I was done with school, or I can't read and write, up to I was a student in nursing school in one of the big cities. And then I would take that and then tailor it to what do I want to prioritize on, making sure these folks can confidently do and recognize in the field to save a life without having to just essentially setting my priorities and my training objectives and making those two meet so that the student is capable. So one of the big things that I wanted to focus on initially, which was very well received and utilized, was proper pressure. Where do we hold pressure? And just using pressure points, because a lot of these guys, supplies and logistics to support it comes and goes. So you'll see some of these ethnics, the squared away ones, they would roll out with a pocket full of sticks essentially as windlasses and cravats around their necks so that they can make these improvised tourniquets. But what happens when they run out of sticks or whatever, or they run out of supplies, showing them, hey, if you hold pressure here. And we did a lot of reps of pressure to buy you that time to put a device in place so that you have hemorrhage control. That was one of my first priorities. Second priority was familiarization and proper application of tourniquets. And so North American Rescue, actually, there was a lot of North American Rescue supplies over there from donations. And that was always the stuff that when you offer equipment from the ethnics, they know, like they don't know, they recognize a cat, a legit cat, and that's what they want. And a part of that is myself, like I've never actually been in a scenario where I have even seen a fake tourniquet, like a Chinese or whatever tourniquet. And I started seeing them break. These Chinese counterfeit tourniquets, like after your first turn, that one was just snapping off, and saw it enough times to where, okay, I could see why they don't want those tourniquets, but there's a lot of them over there. And so we practiced a lot on that. And a lot of this too was, asking the ethnics what they wanted to learn. And then the next thing after HemCon was they wanted to learn, how can I effectively drag my casualties? So then we started practicing and talking about casualty drags, which the training I had as a firefighter came in a lot of help there, of the principle of being a firefighter and having to remove a victim and staying low, and also using webbing. So I carry tubular nylon. I think a lot of rangers carry tubular nylon. A lot of operators carry tubular nylon, very effective tool. But they don't have tubular nylon, but they have hammock strings. hammock strings can act as tube or nylon. So they started setting up, when we would set up camps, they would set up their hammocks, but when we would push out to an operation, they would pull their strings out and set it up in a way that they could rescue a casualty. But with that being said, Dennis, a mistake that I made on my end with that training was I didn't emphasize enough about, if your casualty is able to walk or run with you, make him walk or run with you. And I failed on my end to emphasize that. So there were guys that were getting wounded at, like, arm injury, for example. All he has is an arm tourniquet on. And these ethnics, they resort to their training and they want to help their friend out. And so they just tell their guy, just lay there. We're going to carry you. And ultimately it takes hands away from being able to pull that 360. And also you just have like this massive of guys all in one casualty. So that's a failure on my end on not emphasizing that, but the guys wanting to utilize what they trained. And then we started introducing Rollo. Yep.
Just a quick question before I go into Rollo on the basics, tourniquets, pressure points, tourniquets, and casualty movements. Like, how much time did you have to actually spend to train all those things?
So that week and a half, I got to meet the majority of the ethnics that I was going to be pushing out with. I would say like 70%. And then I would meet the rest of my team when I got to the front, because they were already there working. And training was ongoing the entire time. So when we were out at the front, if we weren't actively involved in an operation or doing a reconnaissance or visiting the IDP camps, the individually displaced people's camps, to provide medical care and just raise their spirits, we were training. So any downtime we had, really, we would re-outfit our gear for the next operation, and then we would look at what area we were templated to go to next, and we would train for that. And that was both on the tactic side and the medicine side. I would say between the split, 70% medicine, 30% tactics. And so a lot of these guys, they haven't fought in an urban environment before. It's been a lot of jungle, and just the way the war has been shifting, and their environment now actually making it into a city or a village. And so we would start talking about, these guys know how to move through a jungle. You don't have to teach them how to move through a jungle, but they don't know how to move through an alleyway or down a street, or where their eyes need to go when they're moving through a place that has 1-story buildings and 2-story buildings and all that stuff. So that's when we started, all right, we might go to this region next to support these guys. Let's talk about urban movement mount operations.
Okay.
And then the medicine was just one step at a time. And then a lot of it too was just based off of our AARs of like, hey, we saw this, let's start. We need more of this to be reinforced, or all right, they're ready for the next thing. They're ready for needle decompression.
Okay. Perfect. So, obviously you always start with the basics, and then once they kind of master that, or they're at least close enough, then you can start pushing forward. So you started pushing forward with Rollo and blood collection?
Yes. So Rollo, blood collection, that started on the camp, and that was just an introduction of talking about, on a very basic level, of just understanding your casualties lost a lot of blood. How do we get them blood back? Let's not flood them with normal saline and that whole route, right? Just everyone kind of understands that concept here, but not so much over there. And once you started just explaining the basic of, hey, your casualties lost a lot of blood because he stepped on a landmine, we need to get him some blood, and that's going to help him. Boom, received. Okay, now how do we do that? They know how to do IVs, a lot of these ethnics, and that's just from all the foreign help that's rotated throughout the years, right? And so that wasn't the hard part. It's then now understanding everything that goes behind blood collection of how do you know your bag's full? Once you have your bag full, how much time do you have to utilize it? Administration, and also recognition of how do we identify who's giving blood to who? And also recognition of who do we want to give blood to? If we have these 50 casualties, who do we prioritize giving blood to? And that portion in itself of recognizing who needed blood was an ongoing reminder, refresher, and using casualties that we were seeing to use as talking points. So it's not just something on paper, it's something that we are actually seeing after every single operation that we're supporting over there. And a lot of these guys, yes, so it was kind of like one of those crawl, walk, runs, right? The first rolos that we utilized, so our second day at the front, pushing towards the front lines, not even at the front lines yet, we supported a operation. And I essentially walked through, talked through, drawing the blood, administering the blood. I decided which casualties were getting blood, and I explained my reasoning to the ethnics that I was investing in. And by the end of it, on our very last operation, the day before I was exfilling out of Burma, on my end, I had a failure on communication on my end of our chain of casualty care. So I was out at the front, heavy fighting going on. An airstrike came in, and one of the pro-democracy fighters was severely wounded. And I could have sprinted to him and gotten to him probably within 3 to 5 minutes. And that was the plan, was all the casualties up at the front. I do a rapid life-threatening injuries and triage, and then I would flush them back to our FSU, which is essentially a 15 to 20 minute drive with a truck. The ethnics saw the casualty, threw him in the truck, and sent him straight back to the FSU, because that's where they knew the doctor was. And this is also a pro-democracy group that I had not had a lot of time to work with either. And so we didn't have as much strong rapport as the rest of the groups I had supported. So they flushed him straight back, and by the time he got back to the FSU, he was unstable, had lost a lot of blood, and the ethnics went straight to work, started working on HEMCON, one medic and his helper. The other medic initiated Rolo. They drew 3 units for this patient, started infusing the units, worked with one of our foreign volunteer surgeons, and the 3 units, and on top of the interventions that the surgeon provided, the casualty left our FSU in a stable condition to that next level of care. And I had no idea this casualty even existed until I fell back to the FSU, and they're like, "Hey, we did it." I was like, "Did what?" And then they're explaining to me what happened, and I was like, "Are you serious? That's awesome." And I go talk to our surgeon, and he's like, "Yeah, man, like they did what we talked about this whole, like what you talked about this whole trip." And I didn't ask them, I didn't supervise them. I had time to set up my own stuff and get ready, and it was essentially I was working with you. And that became, for me, all right, training works. I love training because I can't be here I can't be, as much as I want to be here in this region and help every single person, I can't be here forever. But these guys are. So how do I leave a piece of me so that they can continue doing good work? And that's when I decided that I wanted to be in training and education.
Perfect. Perfect, man. You got the bug. So, quick before this operation, like you mentioned before, like logistics, super important, right? So, like, how did you set up the Rolo? Were you doing Eldon cards on everybody? Like, how big was your donor pool? Like that.
So I wish I would have brought Eldon cards in. I was told from certain volunteers that there were Eldon cards at the training camp. They're somewhere on the training camp in the medical facility. I was like, okay, cool. I'll get there. I'll grab the Eldon cards and I'm going to test every single guy we can. I get there. There's no Eldon cards. So I was like, okay. But from asking around, at a minimum, I knew the foreigners' blood types. And I was there with one of my ranger buddies that we were in the same platoon together, and we were both Rolos. But obviously, that was kind of like our last resort, right? I was like, I'd rather just ethnic to ethnic, but if it comes down to it, we'll give our blood for them, because I'd like to keep pushing to the front. I don't want to delay my time and my buddy's time of pushing up to the front. And luckily, a lot of these guys that are from major cities and stuff like that before the revolution, they did have some kind of healthcare and understanding of, they knew their blood types. And also a lot of these students, or the ethnics, they were able to, one of the providers that was on the camp teaching medics on a provider, or essentially up to a paramedic level, but from a provider, they use pretty much microscopes to just identify blood types. And pretty much everyone was either A-pos or O-pos, ethnic-wise. And then I couldn't test for any bloodborne pathogens or any diseases, really. I didn't have that capability. And that's where I relied on the fact that a lot of the ethnics that join Free Burma Rangers are Christians and Catholics that don't necessarily want to be the assaulters on the battlefield for the revolution, but they want to support their assaulters with medicine, and they want to support those being affected by the revolution on the civilian side to provide healthcare, spiritual support, and all that stuff. So the donors that I identified were essentially my O's, and they were also vetted on the fact that, hey, these guys aren't out screwing about. So I kind of took that as justification for reducing the possibility of transmitting diseases, with the exception of malaria. But then I also have the understanding that everyone here has had malaria, if not at some point in their life, in the last year or 2 years. So if my donor had malaria in the last year, I was like, okay, it's fine. This casualty probably had malaria in the last year, and that's the least of his worries. And I had no capability of testing titer levels either. And that's just something that you just kind of accept with that, right? And until I can get resources to do those tests at a secure location, it's just something that we have to roll with for now. And I kind of accepted it, and not your textbook medicine, right, of being approved in the US. But given the environment and the amount of casualties and how frequently they're getting it, I was like, that's a risk that I'm willing to take. And I didn't have a single reaction to transfusion. But I was also carried the typical epi Benadryl thing just in case. And we talked briefly about, I didn't invest a lot of time on talking about transfusion reactions and to the ethnics. And my biggest reason why I didn't was I started noticing when you pair a lot of negative reactions to a treatment, they tend to focus on that negative reaction a lot more than all the positive, if that makes sense.
100% makes sense, because that's what the U.S. students do, the same thing, right? You can't, like when you were in SOCM, you went through clinical medicine. How many times did a PowerPoint slide about a disease come up and you're like, oh, I think I have that?
Yeah.
Right?
Yeah.
Same kind of thing. You know, they're given information, but they don't necessarily know how to, since they don't know enough about it, they don't know how to risk stratify that thing. I think you're 100% correct. You know, all of those possible diseases, you know, AIDS, hepatitis, malaria, etc., all of those are living people problems, and we're not sure that this guy's going to make it the next 15 minutes, so send the blood.
And Dennis, you know, I compare that to tourniquets and like that education on tourniquets. If you put a tourniquet on, they're going to lose their limb. That outdated a lot. I see it a lot on the EMS side now that I've had some exposure with the EMS community. And unfortunately, there's still a lot of those salty paramedics or providers out there on the streets that a tourniquet is a complete last resort. And I saw some of that in Burma as well, of somewhere down the line, someone had given them like, hey, like your tourniquet should be your last resort. So there were times where I would see an amputation from a landmine and guys are doing a pressure wrap on it. And I'm like, dude, stop. Put a tourniquet on that, please. And
like everybody, yes, after a few hours, like under 2 hours, you want to convert that tourniquet, obviously, unless you're talking about amputation. But there's no minimum time either for a tourniquet. So if you can get hemorrhage control as a tourniquet, get them back to safety, you can go ahead and start trying to convert that tourniquet. Everybody talks about the max amount of time that a tourniquet can be on. There is no such thing as a minimum amount of time either.
That's another thing that a failing point on my end, Dennis, is tourniquet conversion and bringing that tourniquet down a little bit instead of high and tight. And so just a little context. My biggest mass casualty over there was 52 casualties. On top of that, 18 dead. And that all unfolded in a span of 3 hours. And being the most forward element that's responsible for casualty care and understanding from my location to our FSU. So our plan for that initially was that the FNICS said they were going to get vehicles to us. They had a plan and a method to get trucks up to my CCP and flush casualties back to our FSU, which would have been an approximate 15, 20-minute drive, 30 at worst, if they had to stash vehicles along the way due to aircraft presence. And So I was like, okay, well, that'll be awesome. And then we worked out how many trucks we have. So I have a rough understanding of, once I start flushing casualties, when am I getting trucks back, and that whole flow of things. Your typical med plan, just as you would with, hey, I have two Arsoa birds or whatever it may be, time of flight, calculating, check, got it. But the other side of me was like, okay, what happens when these trucks don't come? How long is it going to take us for us to walk? Well, we're going to end up carrying casualties. And this is where I talk to FNICS of like, how do you guys carry casualties? Like, what's the best way? Because we don't have talent letters, what I'm used to. We don't have sketch codes, what I'm used to. They're like, oh yeah, it's easy. We have hammocks. What do you mean? It's like, a hammock's not going to go anywhere. And in my mind, it's like a hammock, you're camping, right? And they're like, no, we have a bamboo lance, which is we'll cut down bamboo and then we'll tie our hammock and then we'll throw a casualty on. Takes 2 guys, carries them, it'll be quick. I'm like, okay. Distance wise, we're still looking at a 2 to 4 hour walk from my CCP to the FSU. And I can't timestamp it accurately, but it was about 45 minutes to an hour. I was like, tactical update, where's my trucks? Okay. They underestimated the route that they were going to take with the trucks because of the brush. They can't make it. Okay. We have to start carrying. And luckily, I had talked to our surgeon and our FSU team ahead of time. And I said, in the event trucks can't come, it's a very delayed evacuation time, and I can't walk with every single casualty. So these guys are going to go unmonitored for the entirety of that walk. So it shifted my triage criteria. And I explained to them what my triage criteria was with our doc and our nurse practitioner to make sure everyone was on board. And it's a lot of, it almost feels like you have to decide who's going to live and who's going to die, right? And it's where I felt what I felt. And so I wanted to make sure everyone was on the same page of, I had my criteria set to give everyone the best opportunity to survive. Ultimately, it boils down to evacuating a lot of casualties that were going to live no matter what first, to clear them out of there so they don't they don't get injured even more from mortaring or whatever it is. So what we ended up doing is we started carrying back those casualties that I had talked about that met that criteria where I'm like, okay, I think this guy's going to survive that carry and they don't need continuous monitoring or treatment. And I will stay at the CCP with casualties that need continuous monitoring. And when by 09 o'clock or 0900, the FNICS were unsuccessful in their attack, and it was a retreat. We waited for the last man from the assault element, and they essentially pulled security for us while my team broke down CCP. And we had our freaking train of bamboos, hammocks, and we started carrying, and I would just walk the line of your typical death march of, I would help carry casualties here and there when the guys were really beat in. And it was hard because you see guys sucking, carrying, and you want to help, but also understanding what's the best thing for you to do right now? What's the best thing for me to do right now? And it's to continually reassess. But you also don't want to be that guy that you're the turd that doesn't want to help carry, right? So I would find myself ultimately sucking into like, I'm going to carry casualty for a little bit. And I'm like, oh crap, I really got to go check on that one guy I was thinking about. And then rotating out. And then that's just something that on the back end, I explained to the guys that were carrying, like, hey man, like, I'm not trying to avoid carry. This is why I'm doing what I'm doing. And it's completely well received, right? It's just internally, I feel bad for the ranger that's not carrying his weight. But I'm carrying my weight in a different manner. And then a big thing too is as my CCP grew and I had more people into my expectant area, and these ethnics were seeing their friends in the expectant area where there's not a lot of help and not a lot of resources being pushed to, but guys are still they're still breathing, they're still alive, but not a lot of work being done. It's a lot of like, hey, can you like go help my friend? Like go help that guy and not taking the time to have an in-depth conversation of like why I'm doing that, but like in the best way possible, how do I explain to them quickly that, hey, there's something else I could do for them, but there's something we could do for these guys over here. So I had never been faced with that problem set before of dealing with a million things, and then also dealing with the fact that someone's friend is on having their last breath. And I was the only foreign medic up there, really. And my buddy he's an AR FAR, so he's super dialed. But operationally, it's all we kind of had. And it's where my time at that training camp paid off of teaching and reiterating HEMCON, because logistically, it's impossible for me to treat all those casualties and lay hands on every single one of those casualties. And so I really only got my hands involved in a handful of situations. Our very first casualty we received a crike. So interventions that I performed during that entire time was a surgical airway, 1 needle D, attempted to reduce an evisceration, and I held pressure a handful of times for the FNX to put on tourniquets, and tightened a lot of tourniquets. But other than that, I didn't tunnel vision down the route of I need to treat every casualty, but more so of I trained these guys to do HEMCON. I just need to reassess. And so that cleared up my time and my capacity to have that actual overall picture. And had I not had the opportunity to train the guys on that, there would have been a lot more guys dead. For example, when I finished the crike, I stood up, did a 360 of my CCP, and 10 more casualties that came in. And so it's like, all right, don't tunnel vision on these casualties. Like, hop in where I can, hop in where it's important. But other than that, you need to be continuously getting that 360 of seeing what's going on, and then even pulling the FNX off one thing and prioritizing them in a different way, because you do have that big picture of what all the casualties you are. Like, hey, stop dressing that wound. I need you to get an IV on that guy so I can get TXA on board. So little things like that of just having that big picture as the medic, especially as the only medic, and trusting your help and investing in your help so that it makes your life so much easier.
Yeah, no, you're absolutely right. I mean, you walk into a hospital in the US or any other Western country, doctors aren't doing absolutely everything for everybody, right? You know, they have a nurse, they have orderlies, they have LPNs. They're giving them tasks and they're going about doing that. And you're going in to, train these people. That's what you need to do to help, offload some hands-on time and offload some decision-making. Is like, hey, this guy needs a tourniquet. Somebody else goes do that. This guy needs his airway repositioned. This guy needs an IV, etc. leg needs to be splinted. So I can save my mental power so that as more casualties coming in, I can continue thinking, right? Because if you get mentally exhausted, pretty soon you start making really dumb mistakes.
Yeah.
Yeah.
100%.
So, anything else? Any other lessons learned that you got from your trip over there that could help our listeners?
Yes. A long list of things that I think the biggest thing is realizing how spoiled I was as a ranger on my deployments and as a ranger medic. The luxury of operating within the golden hour obviously is one that we face repeatedly. But ultimately, it's going back to the basics of what you do in ranger school and hearing reading about Vietnam and the time before GWAT. Over there, we don't have ISR. We have the luxury of doing map recon and even some just really using apps to see satellite images of the AO you're going to be operating in. But then also understanding when were those pictures taken. There's a good chance that, so I was there during dry season. A lot of the photos, the sat imagery that I was getting were during wet season. And so for anyone that doesn't know, the Burma Army has quite the air force that they utilize quite a bit. And so they have all the jets that I saw were Yat 130s from the Russian military, supplied by, they buy from the Russians or donated. I'm not completely sure, but they were Russian aircrafts. And so they utilize those, and they utilize essentially you can imagine the same airplane that you would use to skydive out of, right? So they would utilize that, and they will float around your airspace or over your AO, and sometimes it would only be reconnaissance, so that essentially that was their eyes in the sky, and then they would clear the airspace, and then a jet will come in and hit its targets, and then the reconnaissance plane will come back. The other situation for that same aircraft is that when they're outfitted with mortars. So now they're not only spotting you, but they'll fly over your location, and then they'll open up their cargo door and drop 120s and 81s. So they'll typically drop 5, and sometimes 2 to 6 mortar rounds. And that's something that I've never heard of before. And so that's something that when we encountered it, I referred to the FNX and relied on the FNX of all right, what's up with that thing? And they're like, oh, they drop mortars. They look at us and they drop mortars. I'm like, okay. I was like, then I started thinking when they start dropping, are we going to be able to hear the mortars dropping? So you do hear it. And so it sounds like a collapsed parachute, the same exact sound as I can't describe it any other way than like a cigarette parachute of just that flopping almost, but it's not loud. You have to be listening. And that's what I started. My ears just got very dialed over there. And it came to, you essentially have to conduct SILs in the middle of your operation to listen for these things. And so movement discipline and noise discipline became a huge priority and a huge talking point among our whole team of like, all right, everyone stop moving. Let's listen. And then you'll start hearing it, that collapse parachute, and then you'll start hearing impact. Luckily, once you hear the first impact, if it's a little further away, you know the next little group of drops are going to be a little further away. But at the same time, if you hear it and then it impacts and it's 25 meters away, then you're waiting for the rest of them. So where the reconnaissance thing goes into play, where I was getting at with the map and the satellite reconnaissance, is that you have to resort back to ground reconnaissance and walking your routes. For every day of templated operations, you should be investing in at least 2 to 5 days of ground reconnaissance so that you have all your routes in place and understanding what routes gives me the best cover, but also concealment, because that tree cover, that canopy layer or whatever you want to call it, of them looking down is going to save your life. Those trees work wonders for you as far as concealment. As long as they don't see you, they're not going to be able to accurately drop on you. And also limiting your movement once they're in the airspace so that they're not picking up movement in the area. So a lot of just really being frozen under a tree will save you. And it's uncomfortable. At one point, we were pinned down for 2 hours and received 32 airstrikes in our general vicinity. Like, admittedly, at the time, we had, and this was the operation where we secured that medium-sized valley and village. The Burma army was actually starting to surrender, which the first time really that the ethnics have seen or encountered getting Burma army prisoners. And so we had got radio traffic that they were running and hiding, and Burma army was on the run. So we went to go support finding them, and we came across them. And so we started going through the whole search, the 5 S's, all that stuff of our prisoners. And a lot of these guys were wounded. And after getting that initial security established, without even really thinking about it, I started treating the prisoners. And some of the ethnics I could tell were like, what are we doing here? And some of them just followed my lead on helping me treat. But it's one of those things that's like, we're already so low in resources, and we continue to take casualties, and we don't know when or if we would get a resupply, and we're utilizing stuff on the enemy. And so I finished doing a wrap on a guy, and I stand up, and the first round impacted before the jet broke into the valley, and it impacted probably 50 meters away from us. And I pissed myself, like, instantaneously. And we dove for cover, and we got pinned in that cemetery for 2 hours in that batch of woods, and continue to take airstrikes. Between airstrikes and the reconnaissance plane dropping mortars on us, and I would be laying in my tiny little, the guys are taking cover in between graves and stuff like that, and we're also taking cover, but also keeping eyes on our prisoners so they're not running off, and making sure that our team's good, and I'm laying on the ground and I'm watching the dirt rise from up as I'm like in the prone, and the leaves are falling on us. I had never been so uncomfortable in my life. And had we not invested a lot of time into ground reconnaissance, we would have not had a good route to get from where we were pinned down from to our FSU, because the last thing you want to do is for the reconnaissance plane to track your movement and ant trail all the way back to your FSU. And then that way, our goal was to keep that FSU uncompromised. And we were able to successfully move all of our casualties and bring all of our prisoners and our whole element from that cemetery back to our FSU uncompromised, due to the fact that we did good ground reconnaissance and had good topside cover or topside concealment for us to make that movement. And so how we ended up doing that was, once there was a good lull in the jets coming in, we started that train, and I sent out we sent out a lead element that pushed out about 50 meters ahead. And then we sent the casualty package and all the carriers in the center. And then myself and 3 other guys stayed in the rear. And the reason why we stayed in the rear was essentially we were inching behind the element, and because you know how carrying casualties, it gets loud, especially when you're walking on dry leaves and all that stuff. So it takes away from your ability to hear that down parachute sound. So we essentially inched behind them and just continue to do seals. So anytime we would hear a drop, we'd call it over the net, and then everyone would stop moving, take good cover, rounds start impacting. Okay, get up, move. So it was more of like an early alert system that we could start providing for them. So that was a big thing for us. And then also the Burma Army, they like to strike CCPs. When I was there, one of the CCPs took a direct hit from an airstrike. I wasn't in that region at the time. There were ethnics up there supporting it. One of the Free Burma Rangers ethnic members was killed in that airstrike. The team that was there, they picked up that CCP, moved to the next CCP, and that they got followed essentially by the air, and that CCP got struck again. So a big rule of thumb we had was those guys had been in that CCP for 72 hours. So my cutoff was no more than 24 hours. No matter what, no more than 24 hours. So now you're planning for one CCP and doing reconnaissance for one CCP, but you also have multiple other CCPs in your pocket for when you need it, and your routes from point A to point B and within that is like trying my best to have 2 to 3 routes to my CCP based on ground conditions and air conditions. And that's another thing that I've never dealt with, is not owning the sky. And you're the indigenous force, like you are the underdog, and these guys own the sky, and there's nothing you can do about it. We don't have anti-aircraft, and so we have flight calculators, right? For when we want to, all right, let's see how fast a 60 or 47 can get from A to B to pick up my casualties, or how long is it going to take for him to flush my casualty back to roll 2 or whatever it is. And that's something that's part of your typical med plan before you go out. But we don't have that. But what we can do is take that same concept and calculate templated time for enemy aircraft to show up on target. So you could be like, all right, if they launch out of the nearest facility right away, like their comms are on point and they call it and the pilots are already on the aircraft, how fast will he get here? So that's something that we started utilizing. What else was there? Maximizing your capabilities before aircraft gets there. And so what I mean by that is once we got into fighting inside of these villages that had cement roads, and we knew we had trucks that can be in and out and working within the city almost, I was like, okay, before the aircraft arrives, I want to flush as many casualties out of this kill box and back to the FSU, or at least out of this place that they're going to level. So that way I don't have to be stuck in the CCP with the least amount of casualties I have in the CCP. When we start getting airstriked, the better. So how we coordinated that was I would push closer to point of injury and not so much be the assault medic, but to be as close to point of injury as possible so that I could do a rapid treatment of life-threatening injuries. And then I would coordinate, once I have eyes on my casualty, I can coordinate for the truck to start moving up to me from their cache location, throw them on the trucks, and flush them out of the kill box. And so we utilized that, and it worked really well. We flushed 10 casualties out before the first jets came in. Had I planned that differently of let me establish an actual CCP, sit on my casualties, and then wait for the whole operation to be done to start trickling out and kind of just, even if it's like a minor wound, all that stuff, and like, let me just consolidate. No, it was like, get these guys off my hands. If there's nothing no matter how severe or how like walking wounded, I want them out of the kill box. They're out of the fight, get them out of here so I don't have to worry about it later. All I worry about is, are they going to make it from where I'm at to the FSU? And so stop the bleed, no compromise airway, get them out. And so my patient contact and my chain for that was get up there, tourniquets on, tourniquets good. All right, friggin' airway's good. Call truck. And so tourniquet on, grab them. All right, we start running towards where the truck's going to meet us. Truck comes up, throw them in the bed, truck takes off. And those patient encounters were quick. And it's just something that you just have to take advantage of, because once that aircraft comes up, it just slows everything down because you can't move. You're getting pinned down, or you're just waiting to get hit. That was a big thing. And then med planning, as far as we understand that we have these interventions that we could perform, such as a surgical crike or finger thoracostomy, whatever it may be, but also understanding that after the FSU and we've pushed these casualties out to the next place for the next level of care that they're going to be with for the next couple months, what's their capabilities? If we send them all these complex interventions that we perform, when they get to this facility, what are they going to do? Like, they're just going to wait to die there. And so it's not like being in Afghanistan or somewhere else where you could just call the roll 2 and it's like, hey man, I'm running this operation today. How many beds do you have? All right, cool. And you have that confidence that once your casualty gets there, they're in higher level of care and they'll be able to get good medical care. But over there, you're they're going to be flushed to a jungle hospital, and you have no idea who's working there. And the ethnics are telling you, like, hey, it's great care there. It's a great hospital. But what is great to us? What are they actually capable of dealing with? And so a big push that I had was like, I want to go get eyes on this jungle hospital. I want to go meet these doctors. I want to have a conversation with them. I want to see what their capabilities are, see their facility, and see what injuries and what patients are there, so that I have a good understanding of what's the point of me doing a crike if they get to this next level of care and they're not going to be able to do anything about them, you know?
Right.
So it's just something where it's time consuming.
A quick question about that. I mean, how was the documentation at these hospitals? Because another thing you would look at is like, what are their outcomes?
So I really I didn't ask them a lot about like their documentation process. It was just like a lot of like them giving me a tour of their facility and just asking certain questions. They did have like walking blood banks, which the jungle hospital would go to other like camps essentially, and then receive blood from civilians and come back. But yeah, I mean, these are doctors that were in the major cities of Burma before the revolution, and when the revolution started, they got pushed to the jungles. And in Karenni State, there was only one more jungle hospital left because the rest of them had been bombed. And that was a big campaign of the Burma army, identifying these jungle hospitals and just bombing them. And there was only one left that had not been bombed. And being that there was only one, now I'm looking at times where my evacuation would be 2 days from our FSU to arriving there. And then that just plays into, how do we skin this? Like, am I gonna ride with this casualty for 2 days back to this hospital for continuous monitoring care? Or do I stay at the front where we're still actively receiving casualties? And that's just something that is so situational dependent and casualty dependent that you keep it in the back of your mind, but you're just ready to make that decision based on the tactical environment.
Yeah, absolutely. You know, just like any other operation, like, one, are the casualties stable enough to last 2 days? You know, because the number of providers that would be able to watch them is obviously going to be less, right? You know, do they actually need, you know, what do the casualties need? I would imagine that they'd probably be stable. You know, hopefully they're stable enough to move. So those are the people that would travel. And that's where another thing is just the training that you provide. You know, can I train, you know, one of the local medics to do the monitoring that they're going to be required? You know, whatever pain medication administration, fluid administration, you know, respiratory management, whatever that person would need or those people would need. I train them to do that, which will allow me a little more freedom of maneuver. You know, and if you can't, maybe I do need to do this. So it's just a lot of wargaming, and just ultimately it's going to come down to some kind of risk and reward type matrix.
And that in itself too, Dennis, is something that when I look back and I reflect on how prepared I was for this trip and my capabilities, being that I was a Ranger medic, prolonged field care is not my strong suit. I have a very loose capability and understanding and capability of providing care in that environment. And that's something that I am going to start working on now, is growing that capability. Because with that mass cow that I had mentioned, I break down that CCP, I walk into the FSU with the last group of casualties, and I link in with the doc and the nurse practitioner, the team essentially. And I'm like, hey, just give me 5 minutes. I'm gonna get a drink of water and I'm here to help you. But then when I say like, I'm here to help you, it's like, all right, well, now what's within my scope of practice? Like, how can I actually help you? And that's when I started just like, okay, they need blood. So I initiated Rolo and started working that whole piece, doing Rolo and reassessments of bringing tourniquets down proximal to the wound, doing my tourniquet conversions, things like that. But it's like also one of those things, like it's like one of those, one of those training events where you never know when it's going to end, but now it's reality. It's like, dude, I just want to freaking sit down and eat right now, but there's just so much to do and you just have to keep going. And it's like, all right, I remember turning into like the batch of woods that would break into our FSU. I was like, all right, fuck, I'm about to be done. And I enter the FSU space. I'm like, oh, I'm not done. All my problems that I kind of forgot about because I got them off my hands are still my problem. All right, take a sip of water. It's go time again. What's next? What's next? What's next? And it's constantly that what's next. And even after that, it's like, all right, crap, dude. Our supplies are depleted. And you're going around the morgue and you're taking tourniquets and interventions off of these bodies. And you're washing tourniquets in the river. You're re-outfitting for the next mission or the next casualty. And it's like, did I bring the right supplies? Did I bring like enough supplies? What supplies did I not touch at all? My ruck, Dennis, ended up being a sleeping bag, my hammock, hygiene kit. I had one pair of pants that I wore the whole time, 2 pairs of Ranger panties, 2 shirts, and a solar panel battery pack so I could recharge my stuff. Everything else I dropped. Like all my comfort items I got rid of so that I could carry more med supplies. And it's one of those things where it's not feasible to walk around with like an 80-pound ruck, 100-pound, like a 60-pound ruck. Like it's not feasible. And you start looking at what do the ethnics have? Hey, they have a machete and they have a hammock and like they barely, and they'll survive off a canteen of water for 3 days. I can't survive off a canteen of water for 3 days. So I was always religious on my 100 ounces of water. I wasn't willing to drop water weight. But all the extra stuff that makes your life more comfortable, it makes you comfortable, but it's not going to save someone's life. And you just want to be able to, enough to sustain, but also enough to keep yourself healthy and be able to walk up and down these mountains, if that makes sense.
Oh, it makes 100% sense. That's what they call, work rest cycle. One, you got to sustain yourself or you're not going to be good to anybody. And like the list of problems is endless, whether that be, operational problems, then it goes into medical problems, then it goes into logistical problems, then it goes, and then the cycle just keeps repeating because now you have to refit and get ready to do something else. So the problems are never ending. So you also, as a provider, you have to find a place where, like, I guess my level of skill or my level of understanding is not necessarily important right now. There's a bunch of like little things that other people know how to do. I'm going to tag out for 10 minutes, 30 minutes, whatever it is that you need. If this happens, come tell me. If this patient's vital signs do this, come tell me. If this, the patient's in pain, come tell me. Like whatever criteria for them to get in contact to tell you, hey, I need you, wake you up, whatever it is that you're doing, give them that kind of power. Like, okay, in this situation, come get me. And then you can kind of mentally break free, think about something else, refit your body, get some sleep, whatever it is you need. Because if you don't stay mentally sharp, you're not going to be good to anybody.
Yeah.
So, good lesson learned right there.
I think the other thing that I kind of had to work through and as a contingency for my gear was disbursement of my medical equipment. So one, a lot of the guys that I'm treating, almost all the guys that I'm treating don't have IFACs, right? So that's a luxury that we have, is like at least there's a initial little bundle that you could utilize from and pull from to treat your casualty. But not having that luxury and being able to only carry so much in my aid bag. So I had a minimum package on my body that I would reserve, that I would not utilize in the CCP, essentially. And I had a bag that I called it a CCP bag. And essentially it was a Mystery Ranch size IFAC of just extra blood donation bags, but essentially a lot of tourniquets, chest seals, all that stuff. And I would instruct guys, and I would try to be as religious as possible on pulling out of that bag to treat inside my CCP. So that way, when I was needed outside of my CCP and I was needed to go push up to the front to help bring back a casualty, or even if they were getting bogged down up there and I had to make my way up there, I didn't want to be delayed with, let me refit my aid bag so I could move up there. I wanted to always be ready to, one, either I had to blow out of my CCP because we're compromised or whatever it may be, and I don't have to refit to work on the next casualty. But at the same time, if I myself need to push out of my CCP to go to the front, I can just pick up, all right, I'm ready to go. Let's do this. Because the more time you, as everyone knows, the more time you wait, the patient's still hemorrhaging. The patient didn't start hemorrhaging when you got to the side. The patient started hemorrhaging when he got injured. So every second that I could cut off on my end, I wanted it cut off. And then the other thing is understanding that when CCPs are targeted and when they get hit, what happens if that CCP bag is destroyed? And all I have now is my aid bag. So at the FSU or at the trucks, I always had bags that were pre-packed to be essentially that resupply. So that resupply would be, I'm not tapping into that until I absolutely have to, or my CCP gets hit or something happens to that CCP bag and they could bring it up. So for example, like if it was a contingency that if my CCP got hit and my team was injured and our supplies were wounded, the guys that would come up to us would have a fresh bag to operate out of. And kind of just like how you would patrol, you would keep guys spread out so that one IED doesn't eliminate the whole force, you want to do the same concept with your medical gear. And I think a lot of that too is like when you have QRF, right? You have your own medical package, and you have your medics on there, and they have gear that's fully packed out to go. It's the same concept. It's just being more in tune of like what's actually in that bag. If that makes sense, Dennis.
Yes. Yep. 100%. I don't know. I just want to say, Victor, like I really appreciate you being able to come on and just walk us through your experiences and all the lessons learned, your experience in Burma. And I hope we can do this again.
Yes, I hope so as well. And yeah, any way I could help, really.
Yeah, greatly appreciated.
Of course. It's good talking to you.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.